Okay, the hydrocephalus was essentially defined by Dandy in the 20s of the last century, and it was conceived as a problem between water pouring from the choroid plexuses, an obstruction that was blocking it, and therefore water accumulating in between. And after providing this type of explanation, Dandy added, "This is the best concept I could find, but I don't really believe in it." So it has, people forgot about the second sentence and believed it for decades and decades and decades. But in the last 20 years, many studies have completely changed the thing. So the hydrocephalus is absolutely not what most of the people think it is. Purpose, I mean, basically hydrocephalus is an active expansion of the CSF spaces that is exerted against, at the expense of the brain. So there are several problems. What provides the force? As you know, many cases of hydrocephalus have a normal pressure. What alters the equilibrium between this force and the brain? How do various etiologies impact this equilibrium? And how does the brain recover or not after treatment? Its volume. So that's the main point we are going to look at. Diagnosis of hydrocephalus, that's very easy. I mean, all of you know how to do it. You look for ventricular dilatation, mostly the rounded temporal horns to differentiate it from atrophy. Expanded anterior third ventricle, also to distinguish it from atrophy. There is a stretched septum fornix, which is important. There are effaced pericerebral spaces. We will come to that later. In children, macrogrynia is general, and we like to find a cause. They are classified as obstructive and non-obstructive. But what is important to remember is that hydrocephalus is not a morphology. It is a pathophysiological process with various causes and mechanisms. So what we are going to try is how to try to identify the condition, identify the cause, and identify the mechanism. The tools are very easy. My personal protocol is very simple. T1, we do treat T1 because we acquire in about 5 minutes, and then we reformat in 3 planes, meaning that basically we have a complete anatomical evaluation of the brain. The T2 coronal, to me, is important to show the temporal horns well. The T2 sagittal, T2 fat spin echo is important because it shows you the flow voids along the midline, and I think we should really look at every case, look at the flow voids in the posterior fossa, in the aqueduct, in the fourth ventricle, everywhere. We complete it with T2 Fiesta, CIS, or whatever you want to call it, sagittal, because it gives you a very precise midline and cisternal anatomy, and I like the flare to look at the parenchyma. Then you add, if you're looking for the etiology, if the etiology is maybe a tumor, you will give contrast or whatever. Okay, on the where is it? Yes. On the above line, you have the normal anatomy. Below, this is a case with hydrocephalus. I'm going to stretch a few points. The bulging of the anterior recesses of the third ventricle. If you look at the ventricles, this is very interesting because this is the hippocampal commissure. These correspond to these. So that means that the fibers of the brain are markedly stretched during hydrocephalus, even in low pressure hydrocephalus. In this case, that was a higher pressure. And that means that the fibers that are going around the ventricles are stretched as well. So that's extremely important because this compromises the metabolism of the neurons, I mean of the axons, during the study, during the hydrocephalus. If you do 3D imaging, you see that you have much more details. Normally, a good 3D in a normal patient is able to demonstrate the membrane of Liljeqvist. And you see that here, not only you don't see the membrane of Liljeqvist, but because it's compressed by the ventricle, but you have a nice occlusion of the aqueduct. And in these other cases, you see that all the membranes that are segmenting the pericerebral spaces, meaning that you may have cases of ventricular obstructive hydrocephalus, but you may have cases of cisternal obstructive hydrocephalus. Something that is very important is the diagnosis of the periventricular interstitial edema. It is usually read as an egress of CSF from the ventricle to the tissue. Actually, you have this egress presently. You are absorbing your CSF by the ependymal surface. So this is something else. It is due to the compression of the veins. You can see, where is it? You can see that the veins are stretched here, and they are occluded, and therefore they are not absorbing the interstitial fluid in the deeper part of the white matter. So this is not a way for the CSF to escape, because this is a normal process in normal brain. It is the fact that the veins are blocked and cannot absorb the interstitial fluid in the periventricular region, resulting in an edema that is added to the dilatation of the ventricle. So that's a mass that added to another mass. We are going to look at the hydrodynamics, secretion and absorption, bulk flow, and the pulsatile wire. Anatomy, which is relatively important to remember. The size of the CSF space. Everybody is talking about 40 milliliters in the neonate, 100 milliliters at 12 months, and 150 milliliters in the mature child. This was defined by dilution methods a long time ago. But now we have MR. And using MR morphometry, there was a demonstration that in the adult, the CSF is 275 milliliters, which is much more than 150. The ventricles are 25 milliliters. We knew that from a long time. But that means that the outside, you have 250 milliliters, including 150 milliliters, which are extraventricular in the skull. And this means what? That means that you can expand the ventricles without compressing the brain by 150 milliliters, basically. Another thing that is important is that the brain contains vessels, and all those vessels are pulsating. And this will be the source for the pressure wave we will talk about later. And the other thing is that there is a rigid skull and an elastic spinal canal. That means that the CSF is pushed toward the spine and then goes back during the systole. So there is a back and forth motion of CSF from the skull to the spine. This is a model that was made by Harold Recate a few years ago, and he demonstrated that actually if you conceive a brain that would be a sphere with a ventricle that would be 30 milliliters, something like that, with a 3 millimeters pericerebral space. If you decrease the pericerebral space to 1 millimeter, then the ventricles become 134 milliliters. So when you see a ventricular dilatation, that means that you are just seeing the filling of the pericerebral spaces. But then there is something associated that is very important. Most of the people intuitively think that it is what enlarges the ventricle is the compression of the tissue. But you cannot compress the brain. The only thing that you can compress are gases. And the brain is proteins and fluid and whatever. So that means that actually if you expand the ventricles enough to fill completely the pericerebral spaces, if you still increase the pressure, then the pressure will be against the vessels within the brain. That means that the patient is going to suffer from an ischemic encephalopathy. This is just an example to show you the importance of not looking too much at the size of the ventricles. This is a case of a child who was born with a thrombocytopenia, expanded cisterna magna, and hydrocephalus. He was shunted, and at the age of 6 months, you see that there was a nice result and a good development of the cerebral mantle. And then he came a few months later to the hospital. It was in July. He was not well. And he presented like this. And this scan was read as rather better than this one. And it was assumed that the child was well. The problem was somewhere else. But then the same day, at night, he completely decompensated neurologically. And the fellow who read the the scan, say there is no change from this morning. And actually, if you look at it, you see that there is a little bit of pericerebral spaces here, but there is none here. The ventricles are the same because actually it was almost full at this stage, and the child was dying. And it was salvaged by the fact that the neurosurgeon stick the needle in the ventricles on the CT scan. CSF production, classically estimated half a liter per 24 hours. Again, dilution method, nobody knows what is true in the dilution method. The volume is small, it's only a third of milliliter per minute, and huge because it's 20 times the size of the ventricles. Therefore, when you obstruct the ventricles, that means that there is absorption of CSF because you never see the ventricles increasing 20 times in one day. It's said to be from the choroid plexus mostly, but now it's challenged. Implicitly, it is assumed to be permanent and constant, but there is no reason why in the body there should be a permanent and constant secretion anywhere. And we know that it is decreased in increased intracranial pressure. Actually, what regulates the secretion of CSF is, number one, the perfusion pressure, which depends on the arterial, venous pressure, the PCO2, and the intracranial pressure. Aquaporins are something that was described 20 years ago, and they are water channel. They are special because they carry water and nothing else across the wall of the cells. And it has been demonstrated that there are many, many aquaporin channels along the ependymal side of the choroid plexus, and those are submitted to influences that regulate them. The choroid vessels innervation is important to modulate the secretion of CSF, and also, I mean, you have receptors in the choroid that are able to induce the formation of substances, amines and peptides, that themselves will react with the aquaporin channels in the choroid plexus. So there are everything to regulate the production. Also, there is evidence that there is a non-choroidal production of CSF. Number one, there is a clinical evidence. When you have an obstructive hydrocephalus in a patient, you know those chronic cases with large ventricles and was not chanted, you still have CSF around the ventricles. So that means that you have a secretion, a production, not a secretion, a production of CSF outside of the brain. It has been demonstrated a long time ago using deuterium that you have a free exchange of molecules of water across the ependyma and the pia. And then you have the Virchow-Robin or perivascular spaces that are now called glymphatic. I hate that word, but it acts actually like lymphatics of the brain. They are around the arterial and the venous perforators, and they collect the water from the parenchyma, and this water is going to the subarachnoid space. So that means that basically the brain is able to carry water from the ventricles to the surface of the brain. So those are the space, and the explanation is this, is that you have the production of water that enters into the brain by the capillaries, but then, those are those arrows, it follows the vessels back to the surface. And if you occlude them, like in this case of a mucopolysaccharidosis, then you have a dilatation of the space. If you occlude them with a tumor, like in this case, then you have a dilatation. And this is a case of tumefactive perivascular spaces, which is not explained, but at least that shows about the same thing. Absorption of the CSF, by definition, is equal to production, and therefore it increases with increased intracranial pressure. And there are multiple absorption sites. We all think of absorption through the granulation of Pacchioni. There are multiple sites, and nobody knows what hierarchy of the sites is. Number one, probably the most important in normal conditions, we have the ependyma, because the ependyma is full of another aquaporin, which is the aquaporin 4. And the aquaporin 4 is carrying the water from the spaces from one side of the cell to the other side. You have the subpial astrocytic end feet that are full of aquaporin 4 as well. And those are also along the perivascular spaces. There is a continuity between the water in the ventricles and the tissue, that means with the veins. So across the brain, there is necessarily absorption of water. Of course, you have the arachnoid granulation and the dural clefts in the dural sinuses. And then you have the lymphatics that surrounds the dura. And those have been shown to be especially efficient along the optic nerve, along the olfactory nerve, trigeminal nerves, and all the spinal nerves. So there is absorption there at the outlet of the nerves. The lymphatics surrounding them absorb the CSF. So if we talk now about the CSF bulk flow, traditionally, the classic concept is from choroid plexus to venous sinuses. But in reality, it is likely that in the even in normal condition, the ventricular and extraventricular CSF flows are completely independent. There is a clinical evidence from the chronic obstructive hydrocephalus. If you have an occlusion of the aqueduct, still you're producing CSF around the brain. There is some experimental evidence in the cat where it was shown that the ventricular absorption equals the ventricular secretion. They instillate radiomarkers into the ventricles, and everything was absorbed by the brain and didn't reach the cisterns. And there is a consequence I told you about before. The CSF may be transported across the brain from ependyma to VR spaces. So this is an example, a child who had intraventricular hemorrhage type 3 with a very wide hydrocephalus, and then this patient was felt to be well, so it was followed up. The surgeon didn't shunt the patient, and at 15 months you see that the ventricles are essentially similar, and then you look at 5 years, and you see that the ventricles are still similar, and yet, in the meantime, you always had an occlusion of the aqueduct. That means that there was secretion of CSF around the brain, and that may be true for the spine. In this case, you have this huge ganglioglioma, which is plugging the foramen magnum. The symptoms date from 18 months. There is a widening of the foramen magnum, so that means that the CSF couldn't flow there for a long time. You don't have a flow artifact and then you see that, well, where am I? You see that there is normal CSF into the spine. So that means that the CSF of the spine was secreted by the spine. So there are implications for the normal conditions. If those flows are virtually separated, how do you explain that there is hydrocephalus if you occlude the aqueduct? And that means that the free communication still is very important. The most important thing is that mechanically, because of the pulsation of the brain, you need space to dampen the pressure wave. If you block it in the ventricles, then there is no dampening, and the pressure wave becomes much more acute, much higher. Also, it's very important because if the pressure wave is everywhere, there is no difference of pressure within the ventricle and outside. But if you block it, then you will have a very acute peak in the ventricles and the normal peak outside of the ventricles, meaning that at each stroke, there is a gradient of pressure across the brain. That means that you are pushing the brain toward the wall. Another thing is that, of course, one absorption sector may compensate for another. If you remember the early times of normal pressure hydrocephalus, it was found that there was a pooling of contrast within the ventricles. And, of course, it helps in mixing the CSF, which is full of substances that are distributed all over the brain. So the force that drives the CSF and therefore the hydrocephalus is the pulsatile flow, which is due to the strokes entering the brain, the systolic stroke entering the brain, which displaces a similar volume of fluid. That most of it is blood along the arteriovenous path, but there is also ventricular cisternal CSF, and that goes toward the spinal canal against the compressible sinovenous channels. And this ability to dampen the systolic stroke is called the compliance. So you have a systolic pressure that is both centripetal from the brain and centrifugal from the choroid plexus, and you may have a decreased compliance that may be due to the restricted space, decrease absorption. If you cannot push water across the absorptive surface, then you have an increase of the peak. And the loss of elasticity of the TECA that is assumed to be the explanation for NPO. I'm not going to talk much about NPO because I have not seen an adult for the last 10 years. In any case, it is not accepted by the neurosurgeons that the loss of compliance is the main feature of any type of hydrocephalus. It's not the obstruction by itself, it is because the obstruction leads to a loss of compliance. Okay, you see this systolic stroke by looking at the flow voids, and you see that, for example, here you have a true stenosis of the aqueduct, and you see that you have a straightening of the jet. Here you see that you have a very huge jet in the occlusion of the fourth ventricle, or here the occlusion is at this level, and you see that there is a huge jet. And here, with the suprasellar cyst, you see that again, I mean, the brain is pushing to try to get the water out, and in this case also. So this is extremely important. So now we are going to look at the consequence for hydrocephalus. The definition, number one, you have the non-obstructive hydrocephalus, in which it may be also explained by the decreased water transport to veins and lymphatics. You have the obstructive hydrocephalus, which may be anywhere between the secretion and absorption site, maybe ventricular, cisternal, and the decreased compliance when the ventricles are obstructed within the ventricles and it's outside. And then we have the benign collections of infancy, Bacci, that was a nice Italian word. And, but I don't like the term extraventricular obstructive hydrocephalus to describe this, because strictly speaking, it would include the cisternal occlusion as well. So I prefer the term of Bacci. Surgical classification of hydrocephalus, I mean, it's new, supposedly. I have always been teaching this for 40 years, so I don't see that it's really new. What is important is that number one, they include something where the problem is mostly decreased compliance rather than a problem of obstruction. And also, it doesn't take into account the physiopathology. So I prefer to classify differently. I would say that you have the non-obstructive hydrocephalus, chronic, and the most better example is the normal pressure hydrocephalus, in which you have a loss of mechanical compliance. There may be, but it was not proved, a loss of absorption. And then you have the obstructive hydrocephalus, which may be chronic and acute. The restricted space with restriction of the compliance is enough to explain a chronic hydrocephalus. And it is likely that in a chronic aqueductal stenosis of a child, the only problem is the stenosis of the aqueduct, and actually you have an absorption of CSF that happens normally across the ependyma. But then, if you compromise this absorption, you enter into the category of the acute hydrocephalus, because you block the ventricles, you have an decreased compliance, you decrease the absorption, and therefore you have a buildup of the intracranial pressure. If you have initially an increase in ventricular pressure, then you have an increased pressure in the veins, and all the same, the veins cannot absorb CSF anymore. So the increased intracranial pressure, above all, is a problem of absorption of CSF. And this can be due also to infection or inflammation. External hydrocephalus is explained by the expandable skull, but we have no time to talk about it. Okay, so just those are two examples. If you look really at the cases of acute hydrocephalus, you will see that there is always a reason for the absorption to be impaired. In this case, that was a neonate with neonatal meningitis, and I mean, we know well that in meningitis you don't have, you have an inflammation of the ependyma, and this is very likely to compromise the absorption. And you see that in this child you have the periventricular edema that is due to the compromise of the veins themselves. So it doesn't, if it doesn't absorb the CSF in the periventricular white matter, it's not going to absorb the CSF in the ventricles. And this is a case of tumor, and I show you this image also, and that again indicates that there is a compromise of the absorption. So in the chronic obstructive hydrocephalus, there are a few implications. One of them is that in any case of obstructive hydrocephalus, the ventricular expansion may also increase the absorption surface. So that would explain why some of those children are in good balance with very large ventricles, but they go well, they have a large head, but apparently they are doing well, including intellectually. Also, if you consider that by expanding the size of the skull, you are expanding the surface of the brain, and even if you decrease the thickness of the brain mantle, still the global brain volume will remain normal. So you have a normal brain, and by increasing the surface, you will have a normal absorption, and it may be a compensation, a way of good compensation, and that would explain why some untreated cases of hydrocephalus are doing well. Another thing is that in the ventricular obstructive hydrocephalus, the compliance is lost in the ventricles and not outside, and that's what I said before. There is a pressure gradient across the mantle. Therefore, the brain fills the pericerebral spaces at the first stage, and then the pressure, the ventricular pressure wave compress the vascular bed. And in cisternal obstructive hydrocephalus, you have exactly the same thing, but the process occurs in a segmented CSF, cisternal space, meaning that there is a block of the compliance anyway. These are surgical implications. Number one, if you have an obstructive ventricular hydrocephalus that is acute, that means that you have a high intracranial pressure and you have a compromise of the absorption. Therefore, there is only one way to relieve that, is to put a shunt, because you have a poor absorption, so you have to divert the fluid outside of the skull, and by doing that, the shunt by itself restores the compliance. If you have a chronic ventricular hydrocephalus, the only problem is a problem of compliance. So you can recreate that compliance just by opening the floor of the third ventricle. In obstructive cisternal hydrocephalus, obviously it has to be a shunt, because if you open the floor of the third ventricle and you have acceptations within the prepontine cistern and the suprasellar cistern, there will be no real expansion of the space. If you are dealing with a non-obstructive hydrocephalus, the compliance is lost or the absorption. In any case, because it's extracerebral, you have to shunt the patient. There is nothing to do for the benign arachnoid collection of infancy, but there is something that is interesting. In Africa, in many countries in Africa, it is impossible to follow up the patients. And therefore, they cannot put shunts in those patients because, the rate of complication of shunts in developed countries is quite high, but still higher, of course, in patients in countries where there is no, people cannot do in the village and so on and so on. So they have a treatment that works not bad. It's not as good as the precise indication in the Western world, but what they do, they do ETV and a plexectomy. So by doing the ETV, they increase the space for compliance, and by cutting cauterizing the choroid plexuses, it results in less production of CSF and decrease of the pulsations within the ventricles. So altogether, concur in decreasing the problems with an absorption and decreasing the problems of compliance. So it works not bad. It's the less bad solution. Very quickly, the brain plasticity in hydrocephalus you have to find reason why the patient is going to recover well or not. If you have parenchymal injury due to the causal pathology, for example, the prematurity here with the diffuse PVL, of course there will be no recovery, and that applies to infection and to hemorrhage. If hydrocephalus stayed for a long time, patients over the years lose parenchyma, always. because there is, even in chronic hydrocephalus, there is ischemic encephalopathy. And I have seen a few cases of real arrested hydrocephalus, but I think I count them on the fingers of one hand. And then you have the intrinsic parenchymal plasticity. This is a significant hydrocephalus that was diagnosed in utero. Look at the results. It's not bad at all. That means that actually, in a very young child, if it's a very simple mechanical hydrocephalus, it is possible to get an excellent recovery. So that can be explained. We have the explanation with the preservation of the brain volume in macrocephaly, but there is also the axonal collateral growth or regrowth that is preserved, and there is something that is very important, is the interaction of myelin. You have acute effects of hydrocephalus, subependymal veins and periventricular interstitial edema, and the ischemic encephalopathy. You have the periventricular stretching of the axons, impairing the axonal flow, and the mass effect. And you have the chronic effects of hydrocephalus, which is the gliosis of the subependymal region, decreased capillary density, increased extracellular water, and so on, that has been described. There is something that is very important, is that the myelin is the most potent inhibitor of the growth of the axons and axon collaterals. So in the normal condition, you have a patient, you have an individual that is growing, the function is allowing the growth of the axons, and the activity of the axons in inducing the formation of the myelin, and altogether there is a mutual feedback, and altogether they allow a normal development of the functions. But the problem is that the myelin is preventing the growth of the axons. That's a big problem in multiple sclerosis. And in this case, if you wait too long before you shunt the patient when the tissue is already myelinated, then you lose the possibility of recovery of the brain. So to summarize, I'm sorry, I'm a little bit late, CSF production and absorption sites are many. It's not the simple explanation between the choroid plexus and the granulation of Pacchioni. Loss compliance and defective absorption explain hydrocephalus when the CSF space are obstructed or compartmented, because it's compartmented. And the poor absorption is likely to be responsible for the acute and subacute course. Loss compliance and poor absorption are likely also to occur in non-obstructive, and the mental restoration after CSF depend on the etiology, so you have to try to identify the etiology, duration and severity, and the age and maturation stage, knowing the role of the myelin-associated inhibitors. Thank you very much.